We're going to talk about population health in its widest sense around population health, and not just how do you manage the person that's sat in front of you, how do you manage the whole of the health of your community. The Fylde coast sits within Lancashire and South Cumbria STP, now called an ICS. Fylde coast is one of 5 partnerships across Lancashire and South Cumbria. Most importantly is this bit down the bottom, where across the whole of our STP we now have 41 primary care networks. And primary care networks are at the heart of health management, health system management. We've got the whole of our patch covered, and a primary care network is typically 30 to 50,000 residents, or roughly 4 or 5 GP practices with all of the other healthcare professionals that work in them. And this is what the Fylde coast looks like in terms of the most important people who are our residents. We've got roughly 350,000 residents on the Fylde coast, and we've got a whole range of agencies whose job is to help them and to support them. The Fylde coast, as in any coastal town, is significantly challenged. There's significant health inequalities, particularly in the more densely populated urban element of the town, where life expectancy is significantly lower than the UK average, and you will find that in any coastal town across the UK. And all of these agencies have agreed to work together, to work collectively as a fully integrated partnership, but broken down into 10 primary care networks of roughly about 35,000 residents to each primary care network, roughly 5 or 6 GP practices to each primary care network. But all of these other agencies, our local authorities, our mental health trust, our acute trust, they are all in agreement that their staff are very much focused at a primary care network level, because that's where all of the work and all of the direct care takes place. I'm going to talk about the National Primary Care Network Maturity Matrix. The Maturity Matrix describes a journey from not working as a primary care network at all to being fully functional and fully integrated and fully addressing the health needs of your community. And what it isn't, it is not a race to get to the right-hand side of this page. There are no gold stars for getting onto the right-hand side as quickly as possible, because what you'll do is you'll fall over somewhere in the middle. The most important part of this maturity matrix happens at the left-hand side, because the left-hand side, this bit here, this step 1, this is all around building relationships. This is all around building trust, because in no way can anybody start to bring around transformation if those relationships aren't in place. And the longer you spend within your primary care network developing those relationships, the better you will be when you start to think about, well, what are we going to do then? The second step is then starting to think about why. Why do we want to work in a different way? Why do we want to work in a more integrated way? Why do we want to work with the next door practice? Because we haven't spoken to them for the last 20 years since they nicked our receptionist or our nurse. Why should we want to work with social workers? Because we don't know what they do anyway. This is really important for that collection of whoever you are within that network to start asking yourself why. Why do we want to work together? Because the job is to address the health needs of your community. So what are the health needs of your community? And how can you work in a different way to better address those health needs? Because those health needs are often very, very complex. And managing a complex situation in a 10-minute consultation between one clinician and one patient is never going to transform the life of that resident or of that patient, and will often result in a series of further 10-minute consultations. Because complex health needs require integrated care, multidisciplinary team working, a whole spread of clinicians across a community, and most importantly, everything we do, we co-produce with our residents. And then you can move into what are you going to do, which is pretty much the next step. And then the final step is around earned autonomy, taking delegated responsibility for budgets and influencing the commissioning cycle. And that's when you end up at the right-hand side of the page. But don't be in any rush to get there. One of the other big enablers is aligning clinical decision-making with financial responsibility. And certainly one thing that has got in the way over the last however many years is payment by results, tariffs, hospitals generating income by increasing activity. And that just generates more activity and it sucks funding into hospital-based care. So what we are doing on the Fylde coast is moving away from payment by results, moving away from activity-generated care, and moving to a system of buying, say, a year's worth of care for individual patients, and delegating some budgetary responsibility down to primary care networks. So primary care networks have a handle on their total spend. They are responsible, if they want to, for redesigning care pathways, and then any underspend generated by their care pathways, they're able to reinvest within their community. So that's aligning clinical and financial responsibility. So what does that actually mean for the clinicians that work on the Fylde coast? But far more importantly, what does it mean for the residents of the Fylde coast in terms of trying to encourage people to lead healthier lives and be responsible for their own care? So I want to introduce you to Fleetwood, which is a fantastic little coastal community, resident population of about 30,000. Our main industry used to be fishing, and our trawlers got decommissioned in the early 1970s, and nothing has come along since there to replace the loss of the fishing trade. So we've had long-term unemployment, we've had long-term lack of investment in the town's infrastructure, and hand in hand with that, we now have significant health inequalities in the town, with life expectancy about 10 years below the England average. And if you go 6 miles down the coast to the most affluent part of the Fylde coast, there's a 17-year difference in life expectancy for purely travelling 7 miles. This is our scale of deprivation in the town. More than 50% of our residents live in the lowest quartile of being disadvantaged in the country, and 60% live in the lowest 2 quartiles. We have any long-term condition that you can name. We have at least twice the national prevalence of anything, twice the COPD, twice the heart failure, twice the dementia, twice the obesity, twice. When it comes to stuff like mental health, we've got 3 and 4 times the national average. When it comes to things like drug and alcohol misuse, we're way off the scale. Premature death from liver disease is probably the commonest cause of death under the age of 40 in the town, and dying of liver failure is a miserable way to die. So how are we addressing that? These are the partner agencies that are all part of what we call the Fleetwood Primary Care Network. So it's not purely the 3 GP practices, it's our local authority, it's our community pharmacy, it's our mental health provider, it's our community nursing, it's our community therapy, it's our dental practice as well. And you might think, so what's the role of dentistry in this? Well, it's huge. Fleetwood, we've got the worst children's oral health in the country, with tooth extractions and with fillings. And your dental health is a direct correlation to your actual physical health. So involving our dentists is really important. This building is open 365 days a year, opens at 8 o'clock in the morning and it shuts at 10 o'clock at night, and acute and routine services are provided from this building by all of those partner agencies working in an integrated way. We have a load of IT in place. All our senior clinicians, certainly our GPs and nurse pracs, they're all fully mobile. They don't have a PC in their room. They have laptops and they can work from home and they can do email consultations and the like. So we have home working going on in the town. We've opened up EMIS to our community pharmacy. We've got 6 community pharmacies in the town and they've got direct read and write access to the patient record within EMIS. That in itself has been revolutionary for us. That's been happening for 3 years now. And we did it because we could, not that we asked anybody whether we were able to. And that's one of the great things about primary care networks. You don't have to ask permission. If it makes sense to you, just get on and do it. Once community pharmacy have got full access to EMIS, with appropriate education and training, then you can start extending the range of services that are provided in community pharmacy. On the high street, you can start taking long-term condition management outside of a traditional health setting and putting it onto the high street. So our community pharmacies now are starting to manage COPD. From the very initial thought about does this patient have COPD because they keep coming in from cough medicine, COPD-6, organising spirometry and even starting to initiate and manage medication. So what are we doing to address the health needs of our community? The biggest health needs are mental health, and yet we've got 3 different mental health providers in the town. We've got a specialist mental health provider. We've got mental health nurses within our practices working at a primary care level, and we've got mental health nurses working in our drugs and substance misuse service. And back in the day, nobody ever spoke to each other. Everybody was very siloed. Referrals were done in the old traditional method. You fill out a referral form and it gets rejected and sent back to you. Actually now, all our mental health staff are working operationally within a single pathway. So actually gone are the days of having referrals bounce back because those referrals are discussed within an MDT about where is the most appropriate point of care for that patient. Second one we're doing, because of the issues around liver disease in the town. Liver disease is caused by viral hepatitis C, hepatitis B, and also by alcohol. And yet the specialist service for all of that, liver disease, was down at Blackpool Teaching Hospital, 18 miles away, where the DNA rate is 90% of people from Fleetwood. So why not move the clinic into the town? Why not wrap around the whole of primary care around those very complex patients? So they have access to the GP during the clinic, they have access to wound care during the clinic, they have access to mental health services during the clinic. And that's what we've done. We now have an integrated clinic for liver disease, supported by the hospital, but delivered within primary care. The other thing that our dentists are doing is they're providing frontline support for people in residential care. The premise that we've got is that one of the commonest reasons people get really serious infections is malnutrition. Malnutrition is related to poor oral health. If you haven't got your teeth, you haven't got your false teeth, you're more liable to be malnourished. So it's our dentists that are going into our care homes, addressing oral health, hopefully improving nutritional status, hopefully people then get less infections and less severe infections and end up less in hospital. Our dentists are also working with us and picking up stuff like dementia by doing little simple questions during the dental appointments. They're also helping us with the childhood obesity issue that we've got by talking to kids and parents about sugary drinks and so on and so forth. Children and families. When we ask our residents, as we do, what is the most important thing for you? What matters most to you? And they will invariably say the health of my children, the kids of the town. One of the commonest reasons for a child over the age of 5 to be admitted from hospital, if you live in Fleetwood, is self-harm. And those kids are very complex, from very complex families with lots of health and social care needs. So addressing the needs of that kid in a 10-minute consultation is going to do nothing for what that child needs. So, because we have developed a multidisciplinary team for children in our most complex families. Our 20 families in whom those children are at highest risk of being admitted to hospital, and we wrap around them proactive care from a multidisciplinary team. That team is led by a consultant paediatrician who has come out of the hospital 18 miles away, comes into the town. 2 specialist paediatric nurses who've come out of the hospital and come into the town. A GP, adult mental health care, social care and CAMS input. And they provide that holistic, wraparound, proactive care for those families. It's been going about 9 months, and already we're seeing a significant reduction in the number of times those kids are admitted to hospital or seen in A&E. If I go back to, though, the importance of building relationships, because this didn't happen on day one of let's have a conversation about the health of the kids. This happened about 18 months after that conversation started, and that allowed time for those clinicians to get to know each other and start to trust each other. And when that happens, really, really interesting stuff then occurs. Because people start volunteering to do things that you'd never expect them to volunteer to do. And certainly if you told them to do it, they would never do it in a month of Sundays. So access to CAMS. So what's the average length of time when you do a CAMS referral? 6 months? 9 months? 12 months? Yeah? In Fleetwood, it's next Wednesday. Next Wednesday. Because our CAMS nurse said, how's about I do a drop-in clinic for you every Wednesday? You don't need a referral. Just tell me somebody's coming. In fact, you don't even need to tell me anybody's coming. Tell the parents they can just bring the kids in if they like. So and that happens every Wednesday. And that was somebody volunteering to do that. This now is where it gets really, really, really interesting. Because all I've talked about so far is how do you manage illness? How do you manage COPD? How do you manage mental health? All of that stuff. What's far more important is how do you keep people well? And this is this thing that we call Healthier Fleetwood now, which is a social movement that we've been going with for about 3 years. This fellow is called Jonathan. This is a real man. It's his real name. He's been on the telly. Jonathan has got severe mental health problems. He's got bipolar. He frequently self-harms. He spends months in inpatient mental health units. He's also significantly obese, and he's got type 2 diabetes, which requires insulin. He smokes 6 cigarettes a day, and he drinks 2 bottles of vodka a day. The reason he smokes and he drinks is that's the only thing that gets him through today, because he's got no hope that his life is ever going to get any better. And if you've got no hope, why bother stopping drinking? Why bother stopping smoking? So Healthy Fleetwood is all around generating hope. And we work on 3 things that all begin with the letter C. 3 simple things that begin with the letter C. One is connecting people together, literally connecting our residents back together with each other and developing a sense of neighbourliness and a sense of community. And that means bringing people together in a space as human beings and not as patients. 2 is developing self-confidence. The more confident we become, the more we're able to look after ourselves, the more able we are to take on self-care. And you can only become confident by becoming a doer and not somebody that is continually done to. So doing stuff is really important. And then 3rd is control. Our residents are genuinely in control of this whole process. And when we create underspends and when we get given money, it's the residents that decide what's going to happen with all of that. And it's the residents that decide what are the priorities that we work on. We've got a whole raft of what you would call social prescribing initiatives. But these haven't been stuff that have been done by the YMCA or by the local authority. These are things that the residents have decided they want to do for themselves. And we've now got 24 of these groups that are running, and the residents have created their own social prescribing pathway. The health of the kids is so important. We've got a massive obesity epidemic within our children because they're sedentary and they eat ready meals. So we've got a whole program with our schools who are partners in all of this to increase activity levels. Teachers are volunteering. Amazing what people do when they trust you. They are volunteering to do rounders after school. They're putting on salsa classes half an hour before school finishes so the parents can come and do salsa. They're putting on cookery and nutritional stuff to encourage the kids to cook because they've never learned to cook because their parents don't cook. And we have a cookery contest now for every 10-year-old in the town called Fleetwood Young Chef of the Year. You put all that together and you connect residents together. Residents become the doers and not the done to, and so improving self-confidence, and residents are genuinely in control and real magic starts to happen.